Okay, so just as a couple of housekeeping things, please, we'd ask you to mute all your, there you go. As you join the webinar today, we'd ask you to please just mute all your mics. And if you'd like to ask a question, please use the chat boxes. And in the end, we'll give you some time to ask questions. Let me just let a few more people inside. Okay. Yeah, and so tomorrow we're going to be hosted by Dr. Alicia, as she does her session, and the session will be on testing for COVID, and then on Friday it will be with Dr. Eric Rafai and Mr. Tambua, who will be talking about the community quarantine and isolation. I know we're getting on in, we're moving on in time, so we'll probably just jump in and make a start. So thank you once again for taking time out of your busy schedules to come and join us this evening. Okay, so as mentioned earlier, this is going to be the first of many SOPs that we'll be discussing, and we will continue to send out links and invite everybody to come and be part of this discussion, yeah, as we go along. Okay, so just remember that SOPs, standard operating procedures, these are living documents, living, breathing documents. They're constantly changing and evolving. And there's a lot of work that goes into the creation of one of these SOPs. The creators look at guidelines that are made by, for example, WHO, CDC. We look at our neighbors in Australia and New Zealand who've also gone through a lot of issues with COVID and you know, outbreaks in the community. And then what we do is we take all that evidence and we try and contextualize it to our settings here in Fiji. But even then, our settings are very different. Like, for example, things are changing so much, you know, there's so much, our settings are so dynamic that you really can't compare, for example, what's going on in CWM right now to what's going on in Lambasa. And so therefore these SOPs will differ. That's normal. They will differ from whether it's in Lambasa or whether you're having this problem in CWM. But these are the general principles that we're going to be sharing with you today, and we would really appreciate your feedback. And we'll take that into account and we'll try and adjust it. But remember, we have to contextualize everything to where we are and the time of year it is. So if you have a look at this particular one highlighted in yellow, February was when this was last reviewed and implemented. And 5 months ago, the situation in Suva was very, very different from where we are currently. So the SOP will have to continually evolve, and no doubt this one too will be updated. So over the next couple of weeks, next couple of days, couple of weeks, these are some of the SOPs that we will be talking about. A couple of clinical guidelines, and as we come across more, as the need arises, we will continue to share SOPs. So particularly for this one, for healthcare workers, for identifying high-risk healthcare workers, the purpose of this particular one was to make sure that there's a standard that can be delivered to healthcare workers who are exposed to suspected or confirmed COVID-19 cases. So we need to protect our healthcare workers. Our health system is very important. And so that's why this SOP was created. The purpose is to protect our healthcare workers and to ensure that there's consistency in risk assessment and the management of healthcare workers exposed to COVID patients. This SOP applies to all clinical staff, so not just your doctors and nurses, but also the cleaners, the ward assistants, even the security. We had classified in the definition of healthcare workers. Knowledge and definition. So with respect to this particular SOP, and this is something when we talk about a suspected case, remember we're living in the time of a pandemic, and the case definitions continue to change. So this is the case definition that we're currently using. A suspected case is a patient with an acute respiratory illness and no other explanation for that illness, and a history of travel to an area that has local transmission. So anybody with for example, if we've got somebody who's traveled from Suva to Lambasa and they've developed a respiratory illness, automatically you need to suspect COVID-19. Now, this wasn't the case in February, but this is the case today in September, that if you have traveled from Suva and you have gone to a place like Lambasa, and you have respiratory symptoms, you are a suspected case. That's pretty straightforward. A patient with an acute respiratory illness and having been in contact with a confirmed or probable case of COVID-19 in the past 2 weeks prior to the onset of symptoms, you are a suspected case. And a patient with severe acute respiratory illness requiring hospitalization, and again, in the absence of any other diagnosis that explains the clinical presentation, that's your definition, our definition of a suspected case. Probable case is somebody who lab testing is inconclusive, or a suspect for whom testing could not be performed for any reason. For ours here at CWM, we had a lot of patients who were, for example, admitted in St. Giles, who initially we had no knowledge, prior knowledge or history about their previous locations and things like that. We had placed them into a probable case just because of the fact that we couldn't test them and we weren't able to take a accurate history from them. And in fact, we weren't even able to swab a few of them. A confirmed case, obviously somebody with laboratory confirmation of COVID-19, and this could be a symptomatic case or could be an asymptomatic case. As long as you're diagnosed COVID using one of our Gene Expert machines, then you're a confirmed case. And a case investigation, so this is a case under investigation. We're trying to find out whether they have come into contact with someone, and there might be an epidemiological link that we're looking for. So that'll be a case under investigation, but we can't really find out where the contact came from. So for this particular SOP, the three main stages in trying to determine, we basically, when looking at a healthcare worker's exposure, you need to risk assess them. And once you have assessed them as either high risk or low risk, then you manage accordingly. So it's going to reach the point where at some point, each one of us healthcare workers is going to come in contact with a suspected positive case or even a positive case. So once that has happened, then we need to decide whether we fall into the high risk category or the low risk category. And that's why this SOP was created. So you need to assess the activity undertaken by the healthcare worker in related to the patient who is suspected or confirmed COVID. Number one. Number two, then you determine the person's exposure. So was it a high risk contact or was it a low risk contact? And then number three, provide exposure advice in relation to whether it's a high risk or low risk contact. All right, so the first part, assessing the activity that the healthcare worker has done in relation to the person's contact with the positive case. So did the healthcare worker participate in any of the following scenarios with a patient who was confirmed or suspected COVID? So direct physical care, face-to-face contact of any duration, a shared closed space, and this could, so anything that the person was doing inside the room where there was an aerosolized generating procedure. Now, like I said, this was an SOP that was done in February. Some of these have been updated to include things like, did you have a mask? Was the healthcare worker wearing a mask? And was the patient or the suspected case wearing a mask? Because if they both were, then that might might move you into the low risk exposure category. And even what type of mask, like it was the healthcare worker wearing an N95 mask. So during these webinars, we're going to be talking about a few other SOPs. So there's one SOP that's recently been finalized and endorsed by Dr. Chemesa, and that's the rational use of PPEs. Now, when it was endorsed initially, N95 masks were only to be used in COVID wards. But after OSMAT have come and they've reviewed some of our IPC measures, they have suggested that N95 masks be worn by all medical staff. This is particularly for CWM, in CWM. So all medical staff in CWM, we are now being encouraged to wear N95 masks. And this is based on the rational use of PPE SOP. that's just been updated. So I'm highlighting already some of the areas that we need to adjust. And like I said, this is a living, breathing document. So whether you're tuning in today from Lambasa Hospital or Lautoka Hospital, you need to be able to take this document, sit down with your IPC nurses, with your clinical governance committees, with your consultants, and adjust it so that it suits you. And then once you've done that, please send it to us at the Ministry of Health so that we can keep track of these changes as well. All right, so basically, back to this this particular SOP. So that's how you classify. You look at the person's activity in relation to the particular patient. So if the healthcare worker has not had any of the above contexts, then he can continue to work while adhering to IPC measures. So you need to be able to identify whether the healthcare worker was a high-risk contact. Maybe he wasn't wearing his mask, or maybe he was wearing a mask that that was not up to the level of IPC, like maybe he was wearing just a cloth mask, for example, and in contact with somebody who's suspected or confirmed COVID, then you might place him into the high-risk category, okay? But if they're low risk, if they were really good, if they were wearing the N95s, if they didn't spend a long time, more than 15 minutes with the patient in a closed room, then they could be classified as a low-risk first-degree contact. And like we've said over here, low-risk contacts, they can continue working, but continue to adhere to the IPC measures. So that's the first part. The second part now is determining the exposure. So again, we need to look at things like, were they exposed to aerosolizing activities? Was there intubation involved? During the process of taking a nasal swab, did the patient sneeze? That sort of things. And once we're able to determine the exposure, then we'll be able to classify the healthcare worker into a high risk or a low risk category. And again, the best way to be able to do this is sit down with your IPC nurse, with your IPC expert, and try and determine for you in your setting what constitutes a high risk. What constitutes placing your healthcare worker into high risk versus what constitutes placing your healthcare worker into low risk. Like if they were wearing the appropriate PPE, they were the appropriate distance away, those sorts of IPC measures, then they would be placed into the low risk category. So once you're able to determine your exposure, then you move on to the final part of the process, which is actually giving the exposure advice. For example, if the healthcare worker had not adhered to any of the, if the healthcare worker had not any of the above contacts and has maintained the appropriate precautions, then the event is classified as low risk exposure. So then if they are low risk exposures, they can continue work while adhering to IPC procedures. But in addition, they need to report to fever clinics. So again, this was done in February. So in February, we didn't have the gene expert machines in our hospitals. So this part can be, the healthcare worker needs to make sure that they have swabs, for example, regularly. Back in February, we may not have had the checks that we now do before allowing our healthcare workers back into our hospitals. So all those things need to continue to be adhered to. But if the healthcare worker was deemed to have been high risk, they were deemed to have failed in some sort of IPC measure, maybe they weren't wearing the right mask, then they need to be classified as a high risk exposure, and then they need to be stood down, okay? And then when they're stood down, I think some of our different hospitals, I know Lautoka Hospital has their own SOP for what happens when a healthcare worker is classified as a high risk exposure and they're stood down. So if they're symptomatic, obviously they self-isolate. They either get transferred to an isolation facility, or as we're doing in Suva, some of our healthcare workers have fulfilled the criteria for home isolation or home quarantine. Then you can isolate by yourself at home. But basically, once they have been exposed or classified as high risk exposure, then you need to have your SOP in place, your measures in place to cater for this. And again, different facilities will have different processes, and that's fine. Our goal here today is to show you that this is the SOP that exists, And if you want to modify it and make changes, by all means do so, but make sure you let your MS know, and so that it's escalated all the way up to the Ministry of Health, so we're aware of the changes that you've made. We don't want multiple SOPs circulating without the proper endorsement from us, from the Ministry of Health. Okay, and then if they test positive, then there's a whole criteria that that we need to go through. We are looking at now through the advice of OSMET, rating people differently, rating healthcare workers differently. And this is something that we're still working on, and I believe the IPC cell of IMT at the Ministry of Health, they're looking at it at the moment. What OSMET have shown us is from their experience in Australia, you can have healthcare workers who are in COVID wards treating COVID patients, as long as they are adhering to the IPC measures, the donning, the doffing, the the hand hygiene, all of those measures, then they say that you are safe to even go home and go back to your families. So that's one of the areas that we're looking into. If you're able to maintain high levels of IPC and adhere to all your IPC measures, even though you are treating positive patients, you should be protected. So we're still looking at that, at the possibility of us being able to adopt that in Fiji. But remember, we take all these protocols that have been done overseas, and we try and contextualize that. Is that possible in our country? Is that possible in CWM? Is that possible in Lautoka? Is that possible in a private clinic? So it's very important that you contextualize these processes to suit you. This is not a one size shoe fits all. And again, we'd like your input, your suggestions, your comments, so that we can develop this document, so that it's one that we can all use. And then you just go through the processes. If they're positive, if you get a positive test, what does that mean? If there's a negative test, what does that mean? What does that mean in terms of quarantine, in terms of how many days you isolate, in terms of repeating the tests? So we were looking at doing it at day 3, so that you get the results on day 4 and day 12. But again, some of the factors that will be affecting this would be how quickly your labs can turn over the results. Yeah, it's no use doing a day 12 test and it comes out, 3 or 4 days later, and your healthcare worker is still stuck in quarantine. So you need to look at all these aspects before you decide, to follow these changes, or if you want to make any changes to this. And then at the end of the day, the responsibility of the SOP belongs to the healthcare workers. It belongs to the IPC, and also the head of your unit, so the medical superintendent of your hospital or your facility, or the clinical director of your private clinic. They're the people who are responsible for making sure that everybody's adhering to the IPC measures, that all the classification of high risk is something that suits your practice, suits your facility, so all these things need to be taken into account, and the responsibility lies with the head of the unit. So that's basically it for the discussion of this particular SOP. If you have any questions, we will request that you put your hand up, or you can put your questions in the chat platform. Thank you.
Sorry, Dr. Alapati, may I just make a comment?
Sorry, go ahead, Dr. Nigel.
Yeah, thank you so much for the run through on that, Dr. Alapati. Just for the audience in general, I'd just like to reinforce the fact SOP is only valuable if people follow it rigidly. It's not a guideline, it's a very clear step-by-step process designed to ensure our experience of late, particularly, is where we have an SOP, number one, they haven't been properly shared. So I would just remind all of the attendees that when you take your SOP, please share it with all of the staff in your facility. And the other important point is that you have some or develop some mechanism of monitoring their compliance. Because, you know, particularly in the large hospitals, it's very difficult to have people on site all around. So through your management systems, please think about how you're going to monitor compliance to these. Otherwise, we will make mistakes. Thanks, Dr. Alapati.
So thank you, Dr. Nigel. So Dr. Nigel, for those of you who don't know, he works for the facility, which is DFAT support to the Ministry of Health and Medical Services, and he is one of the keys. He assists in making a lot of these SOPs. Thank you. Does anybody have any questions on the risk assessment and management of healthcare workers? So again, if you want to have access to these SOPs, you can send us an email, and we'll be happy to share them with you. Mamatuki, sorry, you have a question?
Yes, Dr. Pari, thank you very much for the run through the SOP, which is very much needed. I just have a question regarding the health assessment, whether it's going to be same across or it will be different in different facilities. Now, my question is, who does the health assessments, the risk assessments at the workplace?
Yeah, thank you, Mamatuki. That's a very good question. The way it's done in places like in Australia, for example, the risk assessments are done, like, for example, if you're in a COVID ward, you have buddies, you have like somebody who actually observes you donning and doffing, and that sort of things. They have IPC nurses on the ground who are actually constantly checking to see that everybody's adhering to the correct IPC measures, the hand washing is done. And that ideally is what should be done here in Fiji as well. That's one of the areas that we see is a little bit weak. And not just in, it's one of the areas that we've seen is a little bit weak, and it's one of the areas that we want to continue to strengthen. So IPC used to be something that only a couple of people knew about. But it's something that especially COVID has highlighted, has polarized the fact that it's everybody's business, starting from whether you're a cleaner to a security, right up to a consultant. If you see someone or somebody that's not adhering to proper IPC measures, you need to correct them. And it needs to be everybody's business. So it's one of the areas, like I said, that we are weak on, and we need to continue to strengthen. Everybody needs to be on the same page when it comes to IPC measures, and this is one of the weaknesses that we are seeing currently with regards to COVID.
So, Dr. Pari, my next follow-up question is, what kind of recommendation would you give us floor to help make risk assessments of staff so that we could determine their risk levels? And because it's kind of very difficult when we work with the SOP team, because they come up with different decisions, and they do determine the risk level per telephone as to how we give informations out. So what are some recommendations that you can give us that will improve this gap?
Okay, so one of the things that we've seen is, because the pandemic is evolving, things that constitute a risk also evolves. And so it's actually very difficult to keep up with the ever-changing, ever-evolving nature of COVID. And so I think the best people to rely on at the end of the day will be our IPC teams. So if you have something that doesn't quite sound right, even though it might be coming from SORT or something, it'll be good to get the advice of the different IPC teams that are around the country. At the moment, the Ministry of Health and Medical Services, the key person there is Serema Vatuvatu. She sits on on the IMT representing representing IPC, infection prevention and control. So if something doesn't make sense, especially if it's coming from the team like the SOT team, it's important that you run it by Serema. She would be the guru, the ultimate in giving the right direction. But if you can't get in contact with Serema, then it would be your relevant IPC teams, and we have these in all the divisional hospitals around the country. So I think that that would probably be the best way to go.
Thank you, Dr. Patil.
Naka, sorry, we had a question from I think it was Dr. Ratumai Tavuki, requesting about where did I see this? Why are there different they're asking about why we can't just have one SOP. So this is, again, it's a very good question. And the answer is quite simple. It's the fact that every facility is different. Like if you take a snapshot of today, what's happening in CWM is very, very different from what's happening maybe in Lambasa Hospital. And so you can't have an SOP that is specifically, you can't have a general SOP because the conditions at CWM are very, very different from the conditions in, say, Lambasa Hospital, for example. You really have to have a look at what the national SOP is and see if it's something that suits your particular facility and at that particular time. Like this particular SOP would have been perfect for CWM in February, but it might not be applicable today. So one of the things that we're having at CWM is because we've had lots of patients being treated, we've had lots of bubbles being created. And if we just adhere to this SOP, then we'll have lots of healthcare workers, lots of doctors and nurses who'll be waiting in isolation, waiting in quarantine areas for their 14 days to be completed. Meanwhile, we're running out of staff on the ground. And at the end of the day, this staff might not be infected at all. And so it'll be a waste of a waste of human resources. So that's why we need to continue to look at these SOPs, look at the current situation that we are facing, and then adjust them accordingly. I hope that answers your question. Dr. Rajiv?
Good evening, everyone. Thanks, sir. So what that February SOP says is that basically you work 2 weeks in a COVID isolation ward, and then you get 2 weeks quarantine, and then you come back to work. So think about it. So a staff nurse will work 2 weeks in isolation wards away from the family, then another 2 weeks in quarantine, and then she spends 1 week with the family. So 28 days without the family contact at all, and then 1 week you spend back with the family, and you then back in the cycle going on. You know that from a psychological standpoint does not justify us to continue with that in the CWM context. Now, so hence we have trying to change the SOP. Now the drawback is because, as Dr. Nigel and Dr. Ripate have alluded, is that we all have these national SOPs up there, which have been all various SOPs from clinical merits to healthcare worker assessment to deaths, but you name it, there is an SOP for there. But it's all at the national level, but it's not given people working on the ground. So that's where we as leaders and as managers or consultants or as NAMs or as fellow doctors, we need to go. And that's where what we have found in CWM is that the people on the ground have no idea about the SOP. So we make all of these noises here on the top level, but nothing on the ground. So we need to change that. Now, as for why we can't have a standard SOP, we are in a different phase of the pandemic in different parts. So the north and the east are probably still in what we call the earlier mitigation, in the containment phase. CW Central Division in the mitigation phase, and by the trends of it, the West will soon enter the mitigation phase. So that's why we just need to keep evolving. And second, the other thing is that we have not seen any scientific evidence. We have discussed it at the CWM consultant level, so at the our IMT level. There is no evidence for a stand-down quarantine after walking in a COVID isolation ward. We have searched, like literally 7 or 8 consultants have searched the whole, done a literature search. We cannot find anything to justify that 14 days off after walking in a COVID ward. Every guidelines from the CDC, WHO, an expert technical WHO, and also the OSPED have said this. You give them proper PPEs to the healthcare worker, and if there is any breach, then you assess as a low risk or a high risk breach. If there's a high risk breach, then you go into quarantine. If it's a low risk breach, you go back to work. And that's as simple as it is. It has to be the consistent message. Thank you.
Vinaka, does anybody have any further questions? Yes, Yvette, go ahead. Thank you.
Hi, so just from experience, this healthcare worker risk assessment has been available. Well, not the local one, but the WHO one has been available since last year. And we've actually been using the WHO one up until our own one was developed. And I'd just like to say that it has worked to the point where most of our staff that were engaged in COVID activities were assessed as low risk. But however, because of at that time, because of the need to, because our guidelines had stated that they needed to be quarantined, they were quarantined. But it just goes to show that it's worked in the sense that every test that they've had since going into that 14-day quarantine has come back negative. At the end of the day, it's important that your IPC measures are in place and that the staff are aware of the PPE selections that they require, that they understand the type of exposures that are there to them. And it's important as well for the HODs to come on board with the risk assessment. At Latoka Hospital at the moment, we only have 3 IPCOs who are doing the risk assessment, and it does take a toll because you have to interview a whole lot of people. So it would be good for the HODs to come on board with this risk assessment, and they can always run it by the IPCOs at the end of the day. Thank you.
So thank you, Sister Yvette. And at CWM, we have Sister Ely and her team. And sorry, Yvette, who was it in Lambasa Hospital again? In charge of IPC?
Tawfiq?
Yes.
Tawfiq.
Yes.
Tawfiq.
Thank you. Sorry, guys, just before this, I just put up a quick poll over here, which I think is important. It's just a quick question, please answer it. Are you aware of all the SOPs and how to get them? This is very important feedback because you guys are the hands and feet of the the Ministry of Health. And it's very important that you know how to access this. And if you don't have access to it, then it's something that we need to address quickly. Dr. Ravi, please. Thank you.
Yes, thank you, Dr. Alipate. Just adding on from what Yvette has said, with the quarantine, I think there was only one healthcare worker who was positive in Nandi. And then later on in the isolation facility, there was one healthcare worker in Zoli. And what you'll see now, there's a lot of healthcare workers in CWM who are positive. But when we teased the data, we found out that out of all these, there was only most likely acquired the infection in the COVID isolation. And most of the infections were actually from the community. So again, with the evolving evidence and what Yvette has said and what Dr. Rajiv was saying, I think that the risk assessment is CWM situation. There's ongoing local evidence that in the COVID facility with the right measures, your risk is very low. The community in Suva transmission is much higher. Thank you.
Dr. Rajiv, no?
Yeah, sorry, just one last comment before I go. There's some 100 people over here in this chat, and I said thank you for Alpate and Nigel for hosting this. I want you all to believe that the PPEs work. If you use the appropriate PPEs, you will save yourself, and above all, you'll be saving your family also. The risk of you taking the disease from the hospital to your family, if you follow all the PPEs, is almost close to zero. So very, very highly unlikely you'll take a disease or the COVID from the hospital to your homes if you follow the PPEs. So we, as the ministry at the headquarters, we are ensuring with everyone to make sure that everyone has appropriate PPEs on the ground. So I want you to all, from this talk today, is just to believe that PPEs do work. Okay? Thank you.
I'm sorry, on the chat, there's a question from Dr. Ronak asking about, are we able to establish risk in a workplace where workers may have been exposed to an index case, not in a health facility? Oh, so I think you may be referring to community transmission, or I think there's a totally different SOP again if you're talking about community transmission. So this one is specifically for healthcare workers exposed, in a healthcare facility. I think the community transmission one will be discussed, or aspects of it will be discussed on the webinar on Friday. Yeah, thank you. Sorry. Yep.
Right, thank you.
Naka, we're approaching 6:45. Does anybody else have a comment or a question that they'd like to ask? We're taking note of your emails. The other thing that we're trying to do is we're trying to create a portal that all healthcare workers can access, that will have all the SOPs there listed. And that's one of the things that we're trying to get out very quickly, just so that we have a sort of standard, at least some understanding of what the standard operating procedures are across the country. Like, for example, one of the things we were looking at was to have the Ministry of Health standard, and then maybe the SOPs that relate to CWM, for example, or CWM in the mitigation phase, something like that. But just it's something that we're working on, and we should have it in the next couple of weeks, hopefully, if everything works out. I'm seeing, sorry, Dr. Nigel, you have the floor.
Thank you, Alapati. I'd just like to say to people, if they are struggling to understand an SOP or to develop it, we have got a standard template for SOPs that has been endorsed by Dr. Jamesa. And anyone should feel free to drop an email to myself, Alapati, and I'll offer whatever assistance I can.
Thank you, Dr. Nigel. Would you mind placing your email in the chat so that everybody can get that? So thank you, colleagues. Sister Ely, please go ahead. Thank you.
Thank you so much, Dr. Pate, for the very resourceful sharing that you've done with all of us this evening. I think It's just one thing that probably, if I may allow to share, is that one thing, the basics of risk assessment is for you to basically understand your risks. Nobody else will be able to assess your risk better than yourself. So basically, looking at this variant, we really need to know that the transmissibility rate is very high among healthcare workers. So the two risks that we need to focus on, one will be going home instead of going into quarantine. So the risks at home, household, and also when you can be also bringing that risks into the hospital. So how do you mitigate better? So like say, for example, before you wear that mask, before you change the mask, from surgical mask to N95. Assess your risks. Please perform good hand hygiene, not only just, you just slide the gel onto your hands. It needs to follow the 8 steps of hand washing. Those are the basic risks of risk assessment. You really need to understand your risks. What are the risks before you leave the red zone? Do you take off the gown and take off the masks as well? And take off the your shield before you leave the red zone, or the mask is still on and it's only the gown that comes off. Those risks, it needs to be assessed very well. And whoever is the overseer in the red zone or in whichever isolation, that person really need to tell you, and that person really need to assess you and be honest with you with your risks. That's why the buddy-buddy system is very important. Please choose a buddy, and whoever that you're with, allow that person to
Sorry, Cecile, you're muted.
There's a lot of healthcare workers that are still partially vaccinated, and this is poses more risks. So what basically I just wanted to add more into what everybody else is saying is the basics of IPC. Assess your own risks, understand your own risks, and the risks that you can bring from home to the hospital. And in the workplace, avoid sitting in groups. If you can bring your own lunch, have it in your own room. So these are the risks that we have seen, that it's not only the risk and the breach of exposure, but it's also on those other gatherings, whichever places, like after work when we gather at the transport area. So these are the other risks we created ourselves, and this can pose us a lot more exposure to healthcare workers. So it's not only exposure to the PPEs, like what Dr. Ravi had explained, that there's very less people has actually got exposed in terms of the risk assessment exposure. So there are other places whereby you get the risks. So you have to assess yourself that before you go back home. So those are the things that you really need to see. Decontaminate your scrub. That scrub does not go into the transport without being decontaminated. So assess your risks every day. The social mixing, we really need to reduce that. Our gathering, whether it's in the hospital, whether it's in the tea room, whether it's during handing overs, all these needs to be risk assessed. And that's something that we really need to decrease our social contacts as we continue to think about COVID and think about the potential risk exposure that we might face in the workplace. So these are the basic things that I just wanted to add in what Dr. Alipate and the rest of the team that has shared this evening, because these are something that we are currently faced with. And if there's something that we need to be vigilant about, healthcare workers, we need to look at our risks ourselves, and we risk assess. And the way to go, go back to the basics. Before you put on those gowns, make sure your hands are clean and are really clean, meaning you go through the process of hand hygiene. You complete the steps of hand hygiene, and it has to be 30, 40 seconds, 20 to 30 seconds if you're using a hand gel. That's the way to go. And if you continue to watch those risks, know your factors that contributes to the exposure, you'll be able to protect yourself, and you'll also be able to protect your family. Thank you very much. Pinaka, Dr. Pate.
So, ladies and gentlemen, colleagues, it's quite simple. If you're not sure about risk assessments, if you're still unsure, we have our IPC experts. These are the subject experts. feel free to use their knowledge. They can make a checklist that suits your facility, your department, the area that you work in. But at the end of the day, there's a lot of, if you just do a quick search on ways that you can reduce your risk as a healthcare worker, there's so many resources that you can look at, that you can read, that you can educate yourself on, that gives you the best opportunity of not contracting this virus. I think we will have one more comment from Yvette.
Hi, sorry, Dr. Krupali had a question. So her question was regarding the COVID vaccination and nurses not wearing gloves. Not wearing gloves is fine. What is important is their hand washing in between each jab. Thank you.
Vinaka, I think Sister Ili, can you also talk a little bit about coveralls? I think that's another important issue that's good to be addressed here, since we're talking a little bit about IPC.
Thank you, colleagues. The coveralls, if you look at the new regional SOP of PPEs, the coverall is not recommended by WHO. It is definitely not recommended, given of the fact that in the process of doffing, there's a higher risk of exposure. So therefore, WHO has not recommended healthcare workers to actually use coveralls. So that is basically why we are discouraging healthcare workers from actually using coveralls across the hospitals. So we have actually repurposed the coveralls for other users, say, for example, for waste management and other purposes. Therefore, it is recommended that you do not use coveralls, but yet we have other PPEs that you are provided with that is available, but then you really need to focus a lot on your donning and specifically on the sequence, and then also in the doffing, whereby you really need to get hand hygiene in between so that you don't get exposed. Even if you get exposed in the process of doffing, you can actually break the chain of infection through hand hygiene. So basically, I just want to stress here to everyone that's listening in, if you're still donning those coverall, please avoid wearing coverall, because the high risk of exposure during doffing is very high among healthcare workers. Naka.
Thank you very much, Sister Ili. I've just promoted you to Dr. Ili, but that's okay. So colleagues, tomorrow we're going to have Dr. Alicia join us, and she'll be talking about the COVID-19 testing criteria. So please feel free to join us then. I'll hand over to Dr. Nigel for the parting comments.
Thank you, Dr. Alapati. And I'd like to thank Liz also, who is a co-host. Really informative, good opportunity for discussion. There's been circa 100 participants, and that's really important. So I'd just like to acknowledge the effort, Dr. Alapati, that you and Liz, Sister Ili have put in to draw this series together. I think it offers a real opportunity in these challenged times to share important information. So once again, thank you very much indeed. And thank you to all the participants for taking time out. I appreciate it.
Said Vinaka. On that note, thank you, colleagues. Hopefully we'll touch base again tomorrow. We've got a record of all your emails. So we'll send you an email, and we'll let everybody know once the website goes online, and then you can access the SOPs directly from there. But please, take care of yourselves, adhere to the IPC measures, keep smiling, keep happy, and we'll see you again tomorrow. And we'll, signing out from Suva.
Good evening, everybody.
Thank you, Liz.
Bye. Thank you. Bye.
Naka.
People clinic sometimes on 8
Sorry, leave. Oh, is again. Pressure.